It's a pleasure for me to be able to conduct this interview. My name is Tim Mullett. I'm the current chair of the Commission on Cancer, and I have the distinct honor to be able to meet with my mentor and colleague, Dr. Lawrence Shulman, Larry Shulman. Larry was the immediate past chair for the Commission on Cancer here in this 2021, and served as my mentor as he was the leader while I was continuing to mature through some of the elements of the Commission on Cancer. Larry, it is a pleasure to be able to see you again. Obviously, I wish we could be in person and sharing a cup of coffee and shaking hands, but that day will come.
Well, thank you so much, Tim, and it's great to be here and spend a few minutes with you.
Thank you. I was had a kind of matured in the CoC under your leadership, but I kind of grew up under leaders like Al Cohen and Dan McKellar and of course you, and watching the CoC go through the challenges over the years of your service as the chair was a pleasure, and seeing a steady hand of leadership that you've demonstrated has been quite a role model for me. And as I think back to where you've been as the leader, I would love to hear your insights on what you feel were your accomplishments. I know what I feel were challenges during the program, and watched you as we moved through that. But I'd like to know what you feel like were your accomplishments during that 4-year tenure, and what are you proud of during the time as your CoC chair?
Well, thanks for your kind comments, Tim. I suppose you could divide my tenure up into the pre-COVID era and the COVID era. In the pre-COVID era, we had no idea that COVID was coming. There were some things that we knew. We knew that cancer care in the U.S. overall was very good, but could be better. We understood that when we compared the survivals and outcomes of patients in the U.S. to some of our European colleagues, we were doing okay, but not as well as we might. And we knew that there was disparities in care, that there were places where patients got unparalleled care, and there were places where patients just didn't have the same access to that level of care that others might. And there were a lot of factors, and we studied those through the NCDB and other mechanisms to better understand where they were, and then to figure out how to work better with our cancer programs, the 1,500 cancer programs that we accredit, to try to raise the level of care everywhere. And there's a challenge. We have a big country. It's a complicated country. We have rural areas, urban areas, areas that are chock full of physicians, and areas where there are very few physicians. Looking at that whole landscape has been a challenge, but I think we've made some progress. We've been able to show that progress with patient outcomes, but we still have a long ways to go. While we were thinking about all of that, as you know, we decided to rewrite the standards. I was part of the team that wrote the standards in 2012, that became active in 2014 and 15. And then we did it again, which is appropriate. You should probably do it every 4 or 5 years as things change. And that was a big undertaking. We did it very efficiently. We had a great team. There was a very inclusive and large team that rewrote those standards. And they got launched in January of 2020. And 60 days later, we were being overrun by COVID and a lockdown. The last year, I think CoC has set an example for how to approach the tremendous challenges of practicing cancer medicine in the face of COVID, and trying to still give our patients the treatment that they need, the diagnostics they need, and so on. So lots happened. We have a lot of work to do, and we're thrilled that you've taken over the reins. It's really been a privilege for me to be the chair for the 4 years that I was. One of the things that I do tell people is that I think that there are two things that change physician behavior. One is payment and one is accreditation. And we're half of that equation. And it's an important half.
I can't agree more. I think it's critical. And programs, whether it's the leadership of a facility or whether it's the boots on the ground in a cancer program, they do pay attention to that level of accreditation, and they have an expectation. They have a lot of pride in their programs, and they want to be able to see that certificate of approval that identifies that they are, by the national measure, achieving that level of quality that their patients deserve. Patients look for that, and so I think that's critical. And I think that the more we demonstrate the value of accreditation, then I think we're going to see alignment of both of those elements of impetus for change. So thank you for articulating that. Yeah, and you've outlined some of the challenges that you've faced when you were the chair, and it was just as I was coming in as the chair-elect in the end of 2019 and the beginning of 2020, and coming in with the new standards and so forth. And then, all of a sudden, what we expected was going to be a year of standing next to each other and leading meetings and so forth became a year of Zoom meetings and discussions about something that we had never obviously heard of before as a novel pandemic. But one of the challenges, I think, was watching these programs pivot to initially a lockdown and then realizing that cancer care must go on. And I think it was very quick how that happened. Can you relate to some of those elements about how you helped to lead that? I know we had a number of webinars, a number of other elements, but there was a lot behind the scenes.
Tim, that's a really good point. I mean, I think one of the things that I've observed over my many years is that U.S. medicine changes very slowly, like turning a big ship. And you turn the wheel and it takes a long time to even change your course by a few degrees. And when the pandemic hit, that all went by the wayside. I think two things are really important to mention. One is that, we cooperate a lot with a lot of other professional groups, but, everybody's in their own space, and there's sometimes some friction. All these organizations, the Commission on Cancer and the American Cancer Society and other professional organizations, came together instantly. We had a common enemy, and that was the COVID pandemic, and there was no squabbling, all the things that we sort of fussed about before we realized were trivial by comparison. And there was tremendous cooperation among the different professional groups. And I think that made a huge difference. The other thing is that we sprung into action in days. We put together webinars with 48 hours or 72 hours of advance notice, and then had 1,000 people view those webinars. And it was really quite remarkable. It was something I would never have predicted. And I think we should be proud of what we've done in really a period of time where we had no experience. We didn't know what this pandemic was going to be like. We didn't know how to manage our cancer programs safely. We're still learning about those. We're going to be doing next week a CoC webinar on vaccination of cancer patients, because the vaccine is now available to some degree. And wherever it's been needed, the Commission has jumped in quickly and efficiently, without bureaucracy, partnering with our other organizations in ways that are really terrific. So, it's something that I'm proud of. I wish we never had this test, but the COVID pandemic test is one I think we've risen to.
Very, very good. Very good. I love this conversation that we have, and I appreciate your perspective in that. And I think one of the things that you mentioned, collaboration with other organizations, and frankly, one of the things that was most valuable for me to watch was your intersection of so many of these different elements. You work in an NCI comprehensive cancer program. You represent ASCO as a medical oncologist, a unique position in the American College of Surgeons Commission on Cancer, and also you work with the National Academy of Sciences, and so I think that all of these areas are opportunities for us to be able to continue to raise our influence. Can you just tell me a little bit about how you felt that the role of a medical oncologist influenced your perspective, and perhaps how you approach the challenges that we see in cancer?
The Commission on Cancer, as you know very well, is not a surgical organization. It's an organization made up of 57 or 58 professional organizations representing every aspect of cancer care. And I think that's one of the things that gives the Commission its tremendous strength and credibility, is that medical oncology, radiation oncology, pathology, radiology, social work, patient advocate organizations, they're all there at the table. They all have a stake in providing cancer care the way that we would like to provide it. And it really is a multidisciplinary organization, but it sits under the umbrella of the American College of Surgeons. And that's easy to understand, because when it was formed, and now 99 years ago, in 1922, surgery was the only modality of treatment for cancer. There was no systemic therapy, there was no radiation, and it was appropriate that the American College of Surgeons rose to the occasion and formed the Commission on Cancer. But things obviously 100 years later are different, and the Commission has adapted. It is a multidisciplinary organization, and there's really no element of cancer care that's not represented in the Commission. But I was the first non-surgeon to be asked to be chair of the Commission. I thought that was a great honor. I still think it's a great honor and a privilege. And I think it happened in part because of the acknowledgement that, we're all part of the team. And, any one of us can be a leader in that team. It doesn't have to be a surgeon. Though we've turned it back over to you as a surgeon. But we didn't do it because you were a surgeon. We did it because of your leadership, skills, capabilities.
Well, thank you for that. But yeah, I appreciate that, and that's one of the real values for us is that multidisciplinary approach. And I think that it really does stand to the credit of the Commission to not stand on tradition, but to actually move to who the best leader at the time was. And so I think that was perfect. And finally, I just want to find out a little bit about about where you think the value of the CoC is, and what does it bring to improve the quality of cancer care?
I think one of the things that became obvious to me is that even within the Commission and within our staff, when we have terrific staff, we don't always realize the impact that the Commission on Cancer has on cancer care in the U.S. We're down in the trenches. We're trying to do better every day. We're trying to do new things. But the reality is that the Commission put cancer survivorship on the map in the U.S. And they did it remarkably. The Institute of Medicine had their famous and telling report in 2006 about the needs of cancer survivorship that we were not meeting, and nothing happened in the U.S. It was a great report, but people just kept doing what they were doing. And when we put the survivorship standard into effect in 2015, suddenly 1,500 programs representing more than 70% of the cancer patients in the U.S. were scrambling around to try to figure out what survivorship care was and how they were going to meet that standard. And before that, almost nothing was happening in the U.S. You can't even measure that impact. One of my colleagues, who's a palliative care specialist, made a public statement, not knowing I was in the audience, at a big meeting, saying that the biggest factor to move palliative care forward in the U.S. was the Commission on Cancer and their standard requiring palliative care. That no other factor has moved that farther, faster. And I don't think we always appreciate that, even among ourselves. And so I'm proud of what we've done. I think it's been a privilege for me to be involved with the Commission and to have a leadership role. But our work is tremendously impactful and has really had incredible effects on how we provide cancer care in this country. I think we should be proud of that.
That's great, Larry. I agree with you. I think that just, the survivorship standard I've looked at and have commented on in other meetings that forced all 1,500 programs to really pivot to move towards survivorship and develop the survivorship care plans. But the dynamic nature of it is that while we developed that, and everybody then began to develop their force for survivorship, their resources for survivorship to accomplish that standard, the agility of the new standard recognized that there were limitations with that and moved forward to be able to say, okay, now that we have your attention, let's take the blinders off and let's take the gloves off and let's let you go with your survivorship resources that you've put in play, and let that force go to develop new programs. And then you tell us what is going to be most effective. And so I think it was brilliant to be able to move in that direction for survivorship, but we are seeing it in so many of the other standards now. And I'm looking forward to being able to carry that message forward as we begin to, or continue to move against disparity in cancer care, and as we continue to move in the direction that's going to drive quality further in our programs. We can always do better, but we've made some great progress, and I can't thank you enough for your leadership and for your mentorship and friendship to be able to move this along. Thank you so much for this time today. It's been a privilege and a pleasure.
Thank you so much, Tim. Thank you for your kind words and for chatting with me.
Yes, sir.